Good morning. This is Joanne Spetz. I'm the director of the Institute for Health Policy Studies, and we are really excited to be having a special webinar today. This webinar is being recorded for people who might not be able to attend today, but who can watch it on their own time later. We are really excited to have Jennifer Yarger here today. She is an associate researcher in the Department of Obstetrics, Gynecology, and Reproductive Sciences at UC San Francisco. She received a doctorate in public policy and sociology from the University of Michigan, where she also completed training in population studies. Her research has focused on advancing and understanding the social determinants of sexual and reproductive health among adolescents and young adults. She is committed to developing and testing interventions that reduce disparities in youth access to quality healthcare. So we're excited today that she'll be talking about disparities in access to telemedicine for contraception among young adults. So Jennifer, I will let you take it away.
Thank you so much. Good morning, everyone. Thank you for inviting me to speak today, and thank you to all of you for joining. Today, I'm excited to share some of my research on telemedicine for contraception with you. Having a little trouble. There we go. So here's an agenda for my talk today. I'm going to start by sharing a brief overview of my background and prior research on access to contraception. And then I'm going to tell you about two current studies on disparities in access to telemedicine for contraception among young adults. I'll then share some future directions for my work. And then finally, I'm really looking forward to hearing your questions and any feedback. First, I'd like to tell you about a personal source of inspiration for my work, my grandmother, Marybelle, who is here in this photo. My grandmother was born in Chicago, but she moved to a farm in Northeast Iowa after marrying my grandfather, who was a corn and soybean farmer, in 1939. As a devout Catholic living in rural Iowa in this time period, my grandmother didn't have access to contraception. Her first child was born about a year after their wedding, and she went on to have a total of 12 children, born mostly 1 or 2 years apart. She cared for her children while keeping up with endless chores on the farm, and for several years they didn't have indoor plumbing and money was always tight. My grandmother died, unfortunately, when I was a child and before I really had a chance to get to know her. But I've heard enough stories to know that she struggled with anxiety and depression. The physical and emotional demands of parenthood were often overwhelming for her. At times, she would drop whatever she was doing and walk off down their dirt road, and my grandfather would have to send one of the older children to bring her back. Now, her children were loved and grew up to pursue education, career, and have families of their own. But I believe that my grandmother, like so many, would have been better off with more say in building her family. Maybe then the stories that have been passed down would have been more about the joy in her life instead of her struggles. And my grandmother's story really instilled in me a deep belief that all people should have the resources and support to decide if and when they want to have children. And this value has guided my career as a social scientist, working to improve access to sexual and reproductive health care. Fast forward to today, we have a wide range of contraceptive methods, and yet access to contraception remains one of the most hot-button political issues in Iowa and really across the country. It is hard to believe that these are the headlines of today. Many individuals, particularly adolescents and young adults, are not able to access contraceptive services. In turn, 1 in 4 women are not using their preferred contraceptive method, which is an important indicator of reproductive autonomy. Studies have shown that socioeconomic status and race and ethnicity are associated with using a preferred method driven by racism and systemic inequities. My research has centered around understanding the social determinants of youth access to reproductive health care, including contraception. I received my doctorate in public policy and sociology from the University of Michigan, where I completed training in advanced quantitative methods, survey methodology, and population science. And then after finishing my doctorate, I wanted to use my skills to study programs and policies aimed to improve youth access to reproductive health care. So I joined IHPS and worked under the mentorship of Dr. Claire Brindis. My work at IHPS included research and evaluation of California's state family planning program, which many of you know, Family Pact. And to share a couple of examples, in one mixed method study, we identified the factors driving a decline in youth participation in the program. In another study, we documented the important role of Family Pact providers in connecting patients with health insurance in the wake of the Affordable Care Act. I also built on my doctoral training in population science to investigate trends and disparities in youth access to reproductive health care. For example, in one study, we demonstrated that adolescents in rural areas have less knowledge of where to go to receive family planning services, and they're less likely to use family planning services than adolescents in urban areas. In another study, we analyzed trends over time in the adolescent birth rate at the sub-county level in California, and we identified how changes in sociodemographic, economic, and service characteristics contributed to changes over time in adolescent birth rates. I've also studied how cost and insurance coverage impact youth access to care. In one study, we showed that concerns about the affordability of contraception are common among young women, even in states with progressive policies. And this is especially true for the uninsured or the publicly insured. And in another study, we identified gaps in health insurance literacy and how these gaps can impede access when young adults are changing insurance. Along with colleagues at IHPS and in the OBGYN department, we fielded 2 large cluster randomized controlled trials testing interventions to improve youth access to sexual and reproductive health care. In one of the trials, led by Dr. Mara Decker, we evaluated a new program integrating in-person and technology-based sexual health education for vulnerable youth in Fresno County. And we demonstrated that this program increased use of clinical health services among youth, including contraceptive services, sexually transmitted infection testing and treatment, and also behavioral health services. The COVID pandemic led me to a new area of research examining telemedicine for contraceptive care, which I'm excited to share with you all today. Research has shown that telemedicine offers an effective way to support contraceptive initiation and continuation. Early in the pandemic, we did a qualitative study on the fast adoption of telemedicine among contraceptive providers. A later quantitative study showed a dramatic rise where 10% of contraceptive providers offered telemedicine before the pandemic compared to 80% during the pandemic. And I want to make a quick note about terminology. Today, I'm going to focus on telemedicine, referring specifically to live, two-way, synchronous phone and video visits. And the term telehealth is broader and encompasses other modalities, including email-based communication between a provider and patient. Telemedicine offers the potential to increase access to contraception by removing the need for an office visit. And this may be particularly beneficial for young people and rural and underserved populations by removing the need for transportation, childcare, and the extra time for an in-person office visit. Telemedicine also may be particularly helpful for young people who are concerned about confidentiality or stigma and don't want to be seen in a clinic seeking sexual health services. However, there's also growing evidence of disparities in telemedicine use for other services by racial and ethnic, linguistic, and socioeconomic groups. So we need to know more about whether young people can access telemedicine for contraception and which groups are having difficulty doing so. 2 peer-reviewed studies have examined disparities in use of telemedicine for contraception. Neither of these studies focused on young people, and they studied a limited set of sociodemographic characteristics. More evidence is needed from youth as well as non-clinic populations in order to capture the experiences of young people who may be in need of care but are not able to access it. The research that I'll share today comes from a study that I've been running in community colleges. And so I want to take a moment just to tell you about this important population. Community college students make up 45% of higher education, but research tends to focus on four-year college students. Community college students are disproportionately low income, first-generation college students, and students of color. Completion rates are very low, with just 38% receiving their degree in 6 years. And in general, there's limited data on the sexual health of community college students. One study that was conducted now over a decade ago found lower use of condoms and higher use of withdrawal and emergency contraception among community college students in California compared to four-year college students. A more recent study by our collaborators at the University of Texas at Austin found that over half of community college students were using condoms or withdrawal. And yet only 19% said that condoms or withdrawal were their preferred method. The majority of students wanted to use one of the other methods that requires a visit with a health provider. So this tells us that there's a large unmet need for contraceptive services among the community college population. The study that we're conducting, which is led by Dr. Cynthia Harper, is a cluster randomized controlled trial testing a multi-level intervention with health providers and students. This study has been a large undertaking. I recruited 20 community colleges to be sites here in California, these are shown on the map. And then our Texas collaborators recruited 9 college sites in Texas. And we overcame a number of challenges to recruit colleges across both states in both rural and urban settings. And I included this photo here. It's a photo of me about 8 months pregnant, recruiting sites at a conference sponsored by our partners, the Health Services Association of California Community Colleges. I've been leading a team of research staff that have enrolled over 1,900 student participants in California and Texas. Students are eligible to participate if they are first-year students ages 18 to 25, assigned female at birth, sexually active, and not desiring pregnancy. Initially, we recruited and enrolled students primarily in person on campuses, and then when the pandemic hit, we switched to a remote model and then later a hybrid model for recruitment and enrollment. And this slide is showing you one of our study flyers. After enrollment, we follow students over time and collect online surveys for 5 years. In order to integrate community feedback into this research, we conducted interviews with students, staff, and faculty at participating colleges. And we also developed a community advisory board. I want to share with you some sample characteristics to give you a better sense of the study population. Most of the participants are ages 18 to 19 at baseline. The sample is racially and ethnically diverse, with the largest group identifying as Hispanic or Latinx. This is reflective of community college populations in both of these states. Half speak a language other than English at home. 2/3 live with a parent. Over a quarter reported food insecurity and 16% housing insecurity. More than 2/3 are first-generation college students. About 3/4 of the sample are in California and a quarter in Texas. And in terms of insurance coverage, about 1/3 had private insurance, 1/3 public, 14% were uninsured, and 12% didn't know their insurance status. The most common methods used in this sample were the condom and pill. That doesn't necessarily mean that people wanted to be using those methods. At baseline, 10% were using withdrawal and 14% were not using any method. And keep in mind that this is a sample of sexually active young people who stated they didn't want to become pregnant. When the pandemic hit, I led the development of a supplementary study to our RCT. Starting in May of 2020, we added a module of questions to each baseline and follow-up survey. These questions addressed the impacts of the pandemic on sexual and reproductive health, health access, education, and economic well-being. And we also added a series of questions on access to telemedicine, which is the data that I'm sharing today. This module has allowed us to look at access to telemedicine in real time. It was also really exciting for me to be able to analyze the data to this supplementary module while the 5-year trial is still ongoing. Although I love fielding surveys, I'm also just very happy when I have my hands in data. So the first study published from these data examines perceived access to telemedicine visits for contraception, studying inequities by food and housing insecurity. And this paper was recently published in the Journal of General Internal Medicine. Basic needs insecurity historically has been high among community college students, and it's grown for all populations during the pandemic due to widespread job and income loss. Previous research has demonstrated that food and housing insecurity are associated with postponing medical care and medications. We hypothesized that young adults who were food and housing insecure would perceive less access to telemedicine for contraception compared to those who were food and housing secure. And now I want to just walk you through the study methods. The primary study outcome was whether they thought it would be difficult to have a telemedicine visit for contraception. The survey items were, how difficult would it be for you to have a phone visit to get a birth control method? And how difficult would it be for you to have a video visit to get a birth control method? And from these questions, we created a dichotomous variable equal to 1 if they said very difficult or difficult to either question. The primary independent variables were 2 separate measures of whether the participant experienced food insecurity and housing insecurity. And as you can see, we included a wide range of demographic and socioeconomic measures to capture common antecedents to both basic needs insecurity and telemedicine access. We also included their state, California or Texas, and the type of method they were using. For the analysis, we used multivariate mixed effects logistic regression models with random effects for site. And the analytic sample included surveys from about 1,400 participants from May 2020 to April 2021. If a participant completed more than 1 survey during this time period, the analysis included data from their most recent survey. So we found more than 1 in 5 participants reported that it would be difficult to have a telemedicine visit for contraception, and video visits were considered difficult more often than phone visits. Telemedicine access for contraception varied by experiences of basic needs insecurity. 30% of the food insecure said that it would be difficult to have a phone or video visit, compared to 19% of the food secure. And we saw a similar pattern looking at housing insecurity. And here I'm showing you the results of the multivariable model. I'm going to highlight key results from top to bottom. First, those who were experiencing food insecurity were more likely to say it would be difficult to use telemedicine than those who were food secure. And the odds of perceiving difficulty here were more than twice as high among the food insecure, and this result was highly significant. Next, those who spoke a language other than English at home and those living with a parent also were significantly more likely to report difficulty with telemedicine. And the other result I want to highlight is that California participants were more likely to say telemedicine would be difficult than those in Texas. Differences by race ethnicity were not statistically significant. And also the results were very similar in the model where we were looking at housing insecurity. So those experiencing housing insecurity were significantly more likely to say a telemedicine visit for contraception would be difficult than those who are housing secure. These results together add to the evidence that we need to address basic needs and security in order to improve access to contraception, whether it's for in-person or through telemedicine. We also asked about perceived barriers to telemedicine for contraception. Here I'm showing you the most common perceived barriers to a video visit, and the responses for barriers to phone visits were very similar. So the most common perceived barrier was needing to have an in-person visit for their method at 41%, even though that's not actually true for many of them based on the method that they're using. The other top barriers were lack of privacy at home and lack of comfort with telemedicine. In additional qualitative work, I found that young people may not feel comfortable with telemedicine for a variety of reasons, including skepticism about the quality of care they would receive through telemedicine. Technology-related barriers were less common, although still a challenge for many of the participants. Lack of reliable internet and not knowing how to use telemedicine were also reported as barriers. A moment ago, I showed you that many young people thought they had to go in person to get their method. We also asked about their preferences, and most stated that they would prefer an in-person visit over a phone or video visit to get contraception. Participants experiencing food insecurity were more likely to report all of the perceived barriers to video visits than the food secure, except for their provider not offering telemedicine. And the housing insecure were more likely to say they would not have the necessary device for a video visit and that they would prefer an in-person visit. Notably, many participants reported a lack of knowledge about telemedicine for contraception. Don't know was a very common response when we asked about each of these perceived barriers. About half didn't know if their doctor or clinic offered video or phone visits. More than a third didn't know if their insurance would cover telemedicine. 20% didn't know if they would need to go in person for their method. So in that last analysis, we looked at whether young people thought it would be difficult to use telemedicine. We know that many contraceptive providers quickly adapted their practices to be able to offer telemedicine, but we don't know if young people are actually using it. And so that's the next question that we asked with this data. We examined whether young people are using telemedicine for contraception, focusing on inequities by health insurance. And I presented this paper at the most recent meeting of the Population Association of America. The federal and state governments have relaxed restrictions in order to make telemedicine more widely available during the pandemic, yet coverage of telemedicine varies by state policies and payer. In addition, the uninsured may have less access to telemedicine due to more limited availability at community health centers. As we know, community health centers are an important source of contraceptive care for uninsured young people. In this study, we compared use of telemedicine for contraception by health insurance coverage among young adults in California and Texas. The primary study outcome was whether the participant had obtained a contraceptive method through either a phone or video visit. The primary independent variable is health insurance coverage. We also controlled for their age, race, ethnicity, language spoken at home, whether they lived with a parent, state of residence, and the type of method they were using. The analysis was somewhat complex. I had to sort out which approach would be best, given that we had repeated measures from participants who were also nested within colleges. We were also doing a supplementary study on top of a randomized trial. With these design factors in mind, we chose to use multivariate mixed effects logistic regression with random effects for site and individual. Our sample included over 1,600 individuals and 6,500 observations collected from May 2020 to July of 2022. If you're paying close attention, you may have noticed that this data set is larger, and that's because it also includes new participants enrolled in the study, and here I'm making use of the multiple waves of follow-up data. Overall, we found low use of telemedicine for contraception. Participants reported using a method obtained through telemedicine in just 6% of observations, and telemedicine use was particularly low among the uninsured. As expected, use of telemedicine varied by method. The largest share of pill, patch, ring, or EC users said they obtained their method through telemedicine, but also some injectable, IUD, and implant users reported using telemedicine. And these are most likely individuals who had a telemedicine visit for contraceptive counseling and then followed up with an in-person visit to start the method. And here I'm showing the results of the multivariable model, including all of our covariates. Compared with those who had private insurance, the uninsured and those who didn't know their insurance status were less likely to obtain a method through telemedicine. And the difference between those with public and private health insurance was not statistically significant. The second result I want to highlight is that participants in California were significantly more likely to obtain a method by telemedicine than those in Texas. We also found that participants who identified as Asian were less likely to use telemedicine than Hispanic participants, and there were no other differences in use of telemedicine by race, ethnicity, age, language spoken at home, or living with parents. As a sensitivity test, we also ran the same model, excluding observations where participants were not using a method at all, and that model yielded similar results. With such a rich longitudinal data set, I was also interested in how use of telemedicine might vary over the course of the pandemic. Overall here, there was little variation. So there was an initial climb from about 3% in May and June of 2020 when data collection began. And then it hovered between 6 and 7% for the rest of 2020, 2021. This year, use of telemedicine has declined slightly to about 5%. I also ran several models that included alternate measures of time, and changes in telemedicine use over time were not statistically significant. So let's review the main conclusions from this research. First of all, access to telemedicine is not universal among young people. In fact, nearly a quarter of young adults said that it would be difficult to use telemedicine for contraception. Although young adults experiencing basic needs insecurity could potentially benefit the most from the expansion of telemedicine, these young adults were more likely to perceive difficulty accessing these services. And the most common barriers were needing to get a method in person and lack of telehealth literacy, privacy, and reliable internet. In the second study, we found low use of telemedicine for contraception among young adults. Telemedicine use was particularly low among the uninsured and those who didn't know their insurance status. And we also found lower use of telemedicine among young adults in Texas than in California. Further research is needed to understand these drivers of state differences. It could be due to differences in state telehealth policy, specifically around telehealth reimbursement. Telehealth policy is quite complex. I created this table comparing current telehealth policies in California and Texas based on a very helpful review of policies conducted by the Center for Connected Health Policy. And the blue font here indicates where there are differences between telehealth policy in California and Texas. California has policies requiring payment parity for private payers, while Texas does not. And also, California has an explicit policy that FQHCs can be reimbursed for audio-only visits, while Texas does not. So telemedicine is likely to remain a valuable tool for contraceptive care going forward. Right now, there's an active conversation happening about policies and other approaches needed to achieve telehealth equity, including voices from the IHPS community. Much of this conversation is focused on coverage and payment parity between telemedicine and in-person care, which is necessary for providers' willingness to offer telemedicine. Drawing from our data, I want to add to this conversation a few recommendations specifically with youth in mind. And the first is to expand youth access to telemedicine for contraceptive care. More specifically, we should prioritize policies, programs, and interventions that address the most common barriers among youth: privacy concerns, telehealth literacy, and the digital divide. Here in California, we have an example of a policy that addresses these barriers. The governor signed AB 32 in September. It permits Medi-Cal providers to establish a new patient relationship using a phone visit when it's related to sensitive services, which includes contraceptive care. They are also allowed to have an initial visit through phone if a patient requests it, or if the patient says they don't have access to video. And hopefully other states will follow suit to allow greater flexibility with telemedicine. Third, we need to provide youth-friendly outreach and education about telemedicine. As we saw in our data, many young people lack basic knowledge about telemedicine for contraception. Outreach and education are needed to increase their awareness that telemedicine might be an option for them. We also need to ensure that education and outreach are accessible to all students, including those facing basic needs and security. And for my last recommendation, we need to invest in clinic infrastructure to ensure that telemedicine is available, but we also need community-level approaches to address community-level barriers. As an example, programs on college campuses can provide students education about telemedicine, along with information about local health centers that offer this type of care. And these programs can partner with campus food pantries and other support services to help reach students experiencing basic needs and security. Finally, I want to tell you about some future directions for this work. In addition to conducting research, I'm also passionate about developing and testing new educational materials to help youth access care. Inspired by our findings from the supplementary study, I've led the development and pilot testing of a youth-friendly educational tool about telehealth for contraception. On this slide, I'm showing you one part of this tool. Our pilot testing showed that this tool improved youth knowledge about telehealth. In the pre-test, 37% knew how to get birth control without going to a clinic, which increased to 97% after viewing the tool. One participant said, "I found the tool really helpful. I never knew you could get these options online and not go to the doctor." We are now in the process of revising the tool based on feedback from the pilot testing. I'm also committed to developing and testing interventions to increase telehealth access. I'm in the early stages of a project to develop and pilot test an intervention that would enable youth to receive telehealth contraceptive services while physically located in schools, libraries, community centers, and other community-based organizations. This model has the potential to overcome many of the barriers that young people face in getting care. I'm collaborating with Dr. Mara Decker on this project, and Fresno Economic Opportunities Commission is our implementing partner. The Office of Population Affairs approved our proposal, and it's pending funding becoming available later in this year. I'm also currently under consideration for a K-12 Career Development Award. Building on the work that I've done on STI care, I'll expand my research to telehealth for urinary tract infections. UTIs, as you may know, are one of the most common outpatient infections in the United States, and about 1/3 of women will be treated for a UTI by age 24. Healthcare costs associated with UTIs exceed $2 billion per year. Telemedicine has been promoted as an efficient and cost-effective mode of delivering UTI care. However, there are concerns about telemedicine access, quality, and effectiveness, including its potential to lead to overuse of antibiotics and misdiagnosis of sexually transmitted infections. Through the K-12, my research will investigate access to telemedicine UTI care among sexually active young adults. I'll examine the quality and effectiveness of telemedicine UTI care in this population. And my findings will inform the development of an intervention with the goal of increasing youth access to telemedicine UTI care, especially among low-income youth, youth of color, and those living in rural areas. Finally, I want to acknowledge how much I have gained over the years working with the IHPS and Bixby Center communities. Many of you who are here on this webinar, I'm very grateful for all of my mentors and collaborators, including those from UCSF and also the University of Texas at Austin. I also want to acknowledge the amazing research teams that I've worked with, as well as our community partners, especially Fresno Economic Opportunities Commission, the Health Services Association of California Community Colleges, and Youth Tech Health. And then finally, I'm grateful to our Community College Advisory Board and all of our participating sites. So that's it. Thank you so much for your time, and I look forward to hearing your questions and any suggestions you might have for this work.
Great. Thank you, Jennifer. So our audience is welcome to put questions into the Q&A box. And we have one already from Justin White. He said first, great talk. And then he asked, in the first study, how do you think about food and housing insecurity as predictors of perceived difficulty for accessing contraceptive care? Are they just proxies for socioeconomic position? Or is there something particular about food and housing insecurity that would make access more difficult?
Yeah, thank you, Justin. That's a really great question. Certainly, food and housing insecurity are associated with other demographic and socioeconomic factors. I think what's unique about food and housing insecurity are the impact that they have on daily life in terms of individuals' bandwidth. So on a daily basis, someone who is food and housing insecure is taking a lot of time and energy in order to determine how those needs are going to be met. And that can take away from the energy, frankly, that they have to seek contraceptive care. And so I think with food and housing insecurity, it is that immediate day-to-day impact. In other research that we've done on the impact of COVID on access to healthcare, when we asked young people why the COVID pandemic had impacted them and their access to healthcare, the most common reason was there's just too much going on. And so I think that gets at the heart of food and housing insecurity and why this has an impact on access to contraceptive care broadly, telemedicine care, independent of other variables like health insurance, use of public assistance, and income.
Great. I'm going to ask a question. I know other questions are coming into the Q&A, but I've been pondering. I know that there's a line of advocacy and thinking that longer acting contraception could also be beneficial for these very similar populations, but generally it's my understanding that those methods are not really telehealth friendly. So I'm curious what your thoughts are about the intersection with, from just a policy and a practical standpoint in terms of how one would assess the policy pathways as well as the methods that might be of most interest or acceptable and effective in reaching populations that want contraception but have a variety of barriers in access?
Thank you for that question. I think there is a misconception that telemedicine is not friendly for certain types of visits, or for certain types of methods, including long-acting contraceptive methods. And so, of course, in order to initiate a LARC method, you do need to be in person for that visit. But there's also a lot that can happen through telemedicine, and particularly with contraceptive counseling. So if you think back to that slide where we broke down use of telemedicine by the type of method that participants were using, we did see about like 6% of participants using intrauterine devices had also said that, yes, I had a telemedicine visit as part of getting this method. And so it's important to have sort of that flexibility that maybe, you know, they're thinking about using a method, and they're more likely to be able to connect with a health provider for the initial visit, just to talk about that, go over their options, and then make a decision. And if they choose an IUD or an implant that would require an in-person visit, then they can schedule a follow-up visit for that. And then there's also, it's important to think about telemedicine then, not just as like, here, you get your method, but being able to support the care they might need later, to talk about side effect management or to talk about switching methods. Switching methods is very common in this age group. And so with telemedicine, we're really thinking about like the full spectrum of contraceptive care that can be offered through this mode.
Great, thank you. Let's see, our next question is kind of a compound question. I'm going to put it all out there at once from Sarah Garrett. So she asks or observes first, increasing community college students' access to telemedicine seems crucial, and a decent proportion of your respondents said they'd prefer in-person visits. So how do you think about balancing those needs and preferences in this work? And Sarah also is curious if you expect that you would see similar patterns regarding UTI telemedicine access or use as you've seen regarding contraception access use.
These are both great questions. Thank you, Sarah. I think I'll take on the first one first. So Sarah had asked, okay, it's hopping around on my screen here.
Yeah, no, yeah. Sorry, I just moved it to the answered section.
No problem. I found it.
Yeah, good.
Yeah, so absolutely. We need to balance young people's preferences and needs with telemedicine. And so one of my concerns with telemedicine is that we all jump on a telemedicine bandwagon and make assumptions that that is what young people want, and that we don't pause to make sure that we're protecting it as an option for them, that we're stopping and acknowledging individuals' preferences, and also the fact that there are these disparities. I think this is, however, also where education really comes in, sort of a first step about saying, I want or I would like to use telemedicine, is knowing that it is even an option and sort of demystifying some of what that might look like. So in other qualitative work and work that we've done in this project with the telehealth education around birth control, it's been really, interesting to see the evolution where at the beginning, a young person may not really have an idea about what telehealth is all about. And then once we explain some more of the basics and that this might be an option, sort of like a little light bulb goes on of like, oh, I think actually that sounds like it would be really convenient, or other benefits might come up. So I think at the end of the day, a first step is just making sure that young people are aware that this is available to them, making it accessible, and then protecting their choice to say, would you like an in-person visit or telemedicine? And then Sarah's second question was around access to telemedicine for urinary tract infections and whether I might expect to see similar patterns with UTI care. So the interesting thing, I think, with UTI care that we don't know about is around stigma and confidentiality. I think with this is an area of unexplored research where, in particular, if someone is newly sexually active and experiencing symptoms of a UTI, I am wondering, and we will explore this in the empirical data, if this then becomes health, if these are symptoms that they feel concerned about privacy and needing to sort of hide that they're seeking care for these, or if this might look more similar to other types of primary care. And so that's sort of digging into one specific area where I'm not sure, but I'm excited to look at this further in future research to unpack, like, is this a barrier that we know exists for contraceptive care with telemedicine? Is it also going to be there for young people who need UTI care?
Thank you. Let's see. The next question is from Janet Kaufman, and I think it's a great one. In that, California and Texas have very different environments. In particular, Janet wonders about the degree to which the differences that you see between California and Texas might be related to differences in Medicaid expansion between the states. And can you comment on this?
Yes, I think the short answer is yes, that absolutely this could be differences due to differences between these states in Medicaid expansion. And beyond that, I think what's really different about California and Texas are the support for the family planning safety net, not just with Medicaid expansion, but other state family planning programs and their funding, differences between Family Pact and the Healthy Texas Women program in terms of their eligibility, differences in how Title X funding is administered in each state. As a result, there's just so much more support for the family planning safety net network in California that I feel like some of that is playing out in their capacity to expand telemedicine services for young people, their capacity to do outreach around this. And so far, I haven't been able to find good data on the availability of telemedicine services between these two states. In our data, what we're seeing is what the young people thought, whether they thought their provider was going to offer telemedicine, whether or not their provider is in fact offering telemedicine, we can't say for sure. Also, like in Texas, we know that there are just fewer providers in general. So certainly there are relationships between what we see in our data and what's happening in the broader availability of health insurance and family planning, publicly funded family planning services more broadly in these two states.
Great. So the next question in the queue, clearly there's a lot of interest in your topic, given the number of questions coming in. This one is from Claire Brindis, who asks, would it be possible to better understand the positive deviance? So those young people who did use telemedicine, were there health services available on any of the campuses? Let's start with that first question. Has there been any thinking for you or with your collaborators on trying to learn more from the people who are the positive deviants in your data set?
Yeah, I love this question. Thank you, Dr. Brindis. So one of the, to date, we have not done this so far around use of telemedicine for contraception and looking at the positive deviance specifically. but it is part of the research design for the K-12 research, that the approach would start with some survey data collection to better understand use of telemedicine for UTI care, and then to do follow-up interviews with a range of young people who have used telemedicine, those who have not, and also to be able to break out a little bit more. I'm interested in the deviants, who I didn't talk so much about in this talk, but those that are using online direct-to-consumer companies. So being able to do more in-depth interviews to understand more of the how, like how did you find out about this telemedicine option? What led you to seek out or choose telemedicine versus in person? You know, to get more into the details about what was that experience like for you, then that is more difficult to do in a survey with closed-ended questions. So I will say stay tuned for that examination of positive deviance to better understand that group. That's a great question.
Great. And Dr. Brindis had a second question about, were there any health services available on any of the campuses in your study that then converted to telemedicine?
Yeah, that is another good question. So in California, most of the community colleges do have campus health centers. And all of the studies that were, all the colleges in our study have some type of on-campus health services. They range very widely from, you know, one part-time nurse to a center with much greater capacity. During the pandemic, oh, let me say one more thing. Texas is a very different story. It's rare to have a campus health center at the community colleges in Texas. All of these colleges shut down during the pandemic. Their health centers closed. I would say that most of them were able to offer at least some limited type of telehealth. And that in some cases was just like answering emails and giving referrals to students. And in other cases, they were able to quickly ramp up and start offering phone or video visits. And so that is it's an important consideration, and we could actually include that as a variable in our analysis. And so that's, I'm not sure that Claire, you were making that suggestion, but I'm going to take it as one. Thank you.
All right. Ooh, just when I thought there weren't more questions. Actually, Cynthia Harper has a question for you. So let's see, she writes, these quantitative findings are powerful, as are the complex analyses that you use to uncover the extremely low use of telemedicine and the fact that it isn't really rising over time. Do you feel like youth serving healthcare providers are aware of this low use, or do you think that they don't even know about it?
That is such an interesting question. And if I had a crystal ball isn't the right metaphor here, but if I had to guess, I would say that this low use would be like more surprising than what some providers would expect. I think it's been such an amazing transformation. I can't speak for health providers, but based on conversations I've had, it's been such an amazing, quick transformation that is perhaps more of the focus, rather than having this like big picture. But that's why the community level data is so valuable, because when we just look at the population who are already seeking services, it can give a different perspective than when you're out in a college and talking to a broader group, including some people who may need services but are not able to access it. So I wish at this point we could have anyone who in the audience who is actually providing these contraceptive services or other telemedicine services to weigh in on that, like a little poll. What do others think?
Well, I'm not seeing more questions come in, and it is almost the top of the hour. So I want to thank you for this really interesting webinar and for your sharing really multiple studies and a pretty comprehensive body of research here. I know some of us are going to be taking opportunities to meet with you later today and with or later this week or next week or in the future. And for everybody, Jennifer's email address is right there on the screen. So if you have questions, you can also email her. So thank you for taking the time this morning.
Thank you, everyone. I really appreciate it.
All right, this closes our special webinar for the day. Everybody, please have a great rest of your day.